So people were afraid of being buried alive because they couldn't tell whether or not someone was actually dead. And then you hear the stories that people were people were afraid of being buried alive, and they found when they would uncover some coffins that scratch marks and looked like people were attempting to get out. So they had this whole fear, this taphophobia of fear of being buried alive. So that's when okay, now the slides are not advancing. Wait, we'll set the technology. So then we heard about being saved by the bell, not that. Also that y'all might remember from your childhood. It was this sort of configuration of the bells that they would attach to coffins. And supposedly if the person woke up and they were alive, they could ring the bell. So then the scientific method came up of the development of the stethoscope, right? They could listen to the heart, determine if somebody was, their heart was no longer beating. So then we did, in the US, there was this need to determine how could we decide when someone was dead. So they had developed this presidential commission to determine how are we going to classify death. And part of this came about with some studies that were done at Harvard. So there was one, the cardiorespiratory, that we knew the heart stopped, the breathing stopped. And then there was the determination of irreversible cessation of all functions of the entire brain, including the brain stem. That's the official legal definition. And there's some significant language in there that we'll come back to in a minute. So are there two types of death, right? The cardiopulmonary type of death, and then the determination of death by neurological criteria. Either one of those is death. They are legal death. And so one of the things, this uniform commission that helps craft laws around the United States to adopt, because it's certainly nice to have the determination of death to be legally dead in one state, you're legally dead in another. So the notion of if we create a uniform definition that the states can adopt, then you won't have these challenges of disparity in the determination of someone's death, something very important to know. So brain death applies to situations where the heart continues to beat and the brain has permanently ceased to function. And this is the definition from the Oxford. And it's sort of, we have this anomaly now because of the advent of ventilators, because the person cannot breathe on their own, but because of ventilators, we keep them ventilated and the heart continues to beat, but they've lost all other, or let me say, all other function, and I'm going to put quotation marks around. So this was the determination of death by neurological criteria, and this started around 68 when Harvard did this study. So you can see that this was earlier on after the advent of use of ventilation, mechanical ventilation. And so these are very busy slides. So for those of you that have participated in determination of brain death, you've probably gone down some sort of algorithm. And so what generally the algorithm is rule out everything else first. So these traumas, you have to rule out intoxication or the effects of drugs. Sometimes it's 3 half-lives of whatever drugs. They have to be normothermic. The acid base needs to be done. The lab work needs to be stable. So various algorithms that are used to rule out other potential causes that mimic brain death before you actually get to, okay, we're determining that they are neurologically dead. So while some people feel like brain death might be a fiction, even the church, the Pontifical Academy, has ruled and said, no, it's not a fiction and has language The brain is dead. The functioning organs are maintained by artificial means. The technology it can preserve the function of these organs. And so it says, even though it highlighted, it continues to meet resistance in certain circles, brain death is not a synonym for death. It's not implied death. It's not equal to death. It is death. So even the Catholic Church recognizes that this is not a thing. So one of the concerns is if you see a patient in the intensive care unit that looks like this, and you ask, is this patient dead? I don't know. I can't tell, right? Because he might be. Because without the determination of brain death, this person could be dead or could not be. And so I think this is also the concern that families have, because they're really challenged when someone has a devastating brain injury and their concern is about brain death. And then they see their loved one in this situation that looks very similar to the person in a bed next to them that will recover or may recover. So here's a little bit of a slide that sort of talks about the determination of these three or several different syndromes that can look a lot like brain death. And so in the someone's fully conscious, right, involuntary, that's a normal state. You have the minimally conscious state. The locked-in syndrome, which to me is one of the scariest things I could ever imagine, is locked-in syndrome, where they're conscious, but they're not able to communicate. I do have a wake-up. And then coma and brain death, you see that they have very similar location with the unaware, unawake, except for the presence of reflexes. So there is a bit of public skepticism or rejection of even the notion of brain death. Some people feel like, oh, it's just a legal fiction that was created for the harvesting of organs. Now, brain death has assisted in the number of organs that are transplantable that are obtained, and we'll see some numbers in just a minute. But that's not the reason for the laws or the notion of brain death, of how that came about. There are also religious objections to brain death. And we'll discuss some of those. Various faith traditions do not accept the notion of brain death. And so we'll talk a little bit about how we go around that. So I like that headline, because if you're suspecting brain death in a patient, generally, even if they're not brain dead, when the determination is made, I'll use the term brain death instead of the longer determination of death, the neurological criteria. But there's something very seriously going on with that patient if you're considering the diagnosis of brain death. So I think one of the things that especially confuses the public is this, when we say brain death, and even journalists, professional journalists will say, well, they're brain dead, but they're on life support. And we need to see about life support. When we call it life support, if they're determined to be brain dead, it's organ support or technology. That's a better way to refer them, because then if you say, your loved one, we performed an examination and they were determined to be brain dead, we're going to remove life support. That seems a bit challenging as far as the language. You could say we're going to remove technology, we're going to remove organ support, but using language very carefully in these situations. And my experience has been language matters a lot, especially in these situations, because oftentimes this determination is going on after a sudden event, a trauma, a car wreck, a stroke, something, a big neurological insult, and the family is very distraught. And then when we start using terminology that confuses them, and they're hoping for the recovery, a lot of them are hoping and praying for the recovery of their loved one, And so we have to very carefully navigate. These are some of the most challenging ethics consults that we receive, because they're oftentimes a very sudden thing has happened, and the family is hoping against hope that their loved one is not dead. So again, brain dead toddler taken off life support. No, if they were determined to be brain dead, it was not life support. It was organ support. So, and then the question is brain death really just this fiction we created to get organs? Well, it does improve the transplant ability of new organs. There are some newer concerns that have come up about this. And, we'll take those up in maybe a future week. So this gets very contentious. One, before organs can be retrieved from someone, they have to meet what's called the dead donor rule. We don't take organs from living people except for, live, kidney transplants, those things. But in general, we're not going to take lungs and hearts and these things from a living person. So the dead donor rule is not a law. It is a rule, though, that is generally accepted. Except, let me just say, I was in my office earlier, and when I go to ethics conferences, there's usually a group there that hands out these pamphlets about organ harvesting in China. There's a dispute about them taking organs out of prisoners and this sort of thing. But in this country, the dead donor rule applies. So we don't take, or organs are not retrieved unless the person meets criteria of neurological death or the cardiopulmonary. And these numbers are a little bit older, so maybe moves around a little bit. So we can see that through neurological death, the number of organs. And the other thing, why these organs they get better organs for neurological death, is because it's a controlled situation. They can take them to the OR, and they've maintained all of the organ support by technology, and then turn it off, wait for the cessation, the declaration of death, and then they can retrieve the organs. With cardiopulmonary, that's a sudden event, it's less controlled, and so the organs, they have fewer retrievable organs, or fewer medical ones. So this is what I consider penalty for failure in determination of death by neurological criteria is very high. You can't have any error. You need to be 100% correct on this, because you're going to see these sort of headlines. Most of the time I see these headlines, usually it's not that the determination of brain death is a faulty clinical entity, it's that it was not performed correct. There are a few aberrations, but so if you see a headline, somebody woke up after being declared brain dead, that's probably a faulty exam. And so harvesting organs from a deceased patient, not completely brain dead. So we get these headlines all the time. And I'm like, you don't want your name in that article, is what I'm saying. And so that's where the using the greatest possible care and understanding. Imagine what the families would feel like in these scenarios if it was your loved one. This is an interesting case in that they were going to take him and take his organs, and a family member went. They were just fixing to take him back to the OR, and scrape did the whole like a plantar reflex on the bottom of his foot. He retracted, and they decided he's not dead. They just brought her back around. He is one of these people that has recovered and doing the talk show circuit. So that's a very controversial case on him. Pregnant and forced to stay on life support. There's been a number of significant cases that have come up where when you have a pregnant woman that has significant insult to the brain and they're declared brain dead, what to do if the fetus, if their unborn child is still alive. And that can vary a lot, depending on the wishes of the family, depending on the laws of the state, obviously depending on how many weeks gestation she has and what the potential for survivability looks like. And these cases are interesting, not as rare as we would think that they would be. I think we've had one at one of our facilities that I can recall right off. So, one of the concerns is about the decision to require the consent for brain depth testing. So the apnea test. And this has become very contentious. In general, what has happened over time is we don't ask for families' consent. The patient's obviously not going to consent because they're the ones being examined. So the surrogate decision maker, the authorized legal surrogate, to act, whether or not they are required to give consent for this testing. And so in general, it has not been required. In Nevada, we see that clinical decision that does not require consent of the person's representative. So that's in Nevada. And in Louisiana, it's the same way. It's not typically required consent to do this testing. There are arguments against it. One of the arguments is that, well, because you do the apnea test, you take them off the ventilator, wait for the CO2 to go up, and watch that because they shouldn't breathe and it should go up, is that if they're unstable, you could cause further harm, further increase in pressure and all these problems. So there's the argument about that. This is a test that generally we should have consent about. There are some other possible motives here. Now, in this case, the family wanted to refuse and the brain depth testing of their child, and the courts ruled against it. And these can be very significant because of the ramifications, because if you can't do the test, then you can't determine the person is legally dead, which means they're likely going to stay in your ICU for quite some time, because these are not the kinds of patients that are readily transferable to a longer care situation. They're generally fairly unstable. So this notion that has come up more recently, and because of people having information they get off the internet, and if they're, if they go home and they're distraught, and what about brain deaths? The doctor mentioned it, and they do a search, they might come up with a website that says, don't allow it. Refuse it if your physician says that they want to do that. And we had a recent case of that, of a child with a devastating brain injury with a self-inflicted gunshot wound, and most of the brain was gone. They weren't even able to close the skull. And the mother said, we're refusing brain testing, and I will have an attorney, and I'm not going to allow it. Now, we knew in Louisiana we don't have to have consent for that, but we had a significant concern that if you brought an attorney into the situation and it got to court, the court could rule that we do require consent, which would mean from that point on, every patient with the concern of brain death would have to have consent. The other concern then that happened is the parents were divorced, and she said, I'm praying for a miracle, which is a whole nother ethics session, right? But I'm praying for a miracle, my child's going to walk out of here. And so we knew this was devastating, not survivable. The ex-husband, who was the father of the child, said, I fully accept it. To me, the miracle would be if his organs go to someone else. So there was the tension between the two. There was the legal tension. And then the poor clinicians who were stuck there saying, we're taking care of this child who is not going to survive this. It was devastating brain injury. But then the notion is, if we can't do the test, we can't make the determination, the child will stay here. She was hoping that a miracle would happen in that interval. So these are the types of challenges that you may see various iterations of in these cases. What we did, that's a good question. One, we slowed down because we could have forced it, because if we don't need your consent, Louisiana does not require that. But the concern was about if we got the courts involved, it could create a really adverse clinical situation from that point on. So what they call the tincture of time, right? We just went slower with it. And then what happened, the brain injury was so devastating, she realized the child's condition just got worse and worse. And it became really obvious to her that this was not recoverable. The other thing that happened is, the physicians were very good about, they brought in all the scans, the CT and all that of the child. And when she saw the amount of brain that was gone, she was like, oh, I thought it was more like a scalp thing that was gone. So working very diligently, because to me, when these situations turn adversarial, like, okay, we're going to do it anyway, then the communication has broken down. And that's the worst case scenario of dealing with a family and patients and loved ones, where it's us against them, as opposed to let's journey together and find out what maybe their misconceptions are. I had one child that was in NICU that had a significant brain bleed, and the mother held out for the longest time. The child's gonna, it's gonna get better. And the neurosurgeon explained how bad it was. And when I went and discussed, she actually thought that it was possible to do a brain transplant. So when we dig further and find out where's the disconnect, once she understood that was not going to be possible, then she was more willing to accept what was going on with this child. And so these are the sort of things that you have to navigate in these scenarios that are really, really sensitive. The other thing that I think, if you get in a scenario about the brain death testing, doing the apnea test, one, I wouldn't pose it as a question. We're going to do this testing. Is that okay with you? I would, and I don't know that this is a subterfuge, I would say we are going to do some testing that helps us determine our care plan, because it exactly does that. The testing we're going to do will determine, because maybe they're not. Okay, we need to know that. That's going to help us with our care plan. If they are, definite change in the care plan. So don't pose it as a question if you don't want to answer this adverse to you. Just say, this is what we're going to do for this. And so that language, I think, is not untruthful at all. And it does state what we're attempting to do. Now, if they say, are you talking about brain death testing? Yeah, absolutely. I'd say, we're talking about an apnea test and these sorts of things. The other thing that I have seen, and I may be getting ahead on some slides, but the other thing that I've seen clinicians doing in some scenarios, and they do it generally, these ancillary tests for brain death testing, which are cerebral blood flow studies, those are generally oftentimes listed as ancillary tests. I think some places do that, and then they don't have to ask about an apnea test. They just do the cerebral blood flow. It's like, we have a negative cerebral blood flow study there, meet the criteria. I was interested to see, when this seemed to be a routine way of doing it at one location, that it meets the criteria, even though it's generally considered an ancillary test. Because it's acceptable, it is acceptable. That is how we can, the diagnosis can be made. So in Nevada, where we saw that, New York, Virginia, consent not required, but in Kansas, California, Montana, consent might be required. So in theory, you could be legally dead in one place and not another because you didn't get consent. In this Montana case mentioned, does not specifically grant the right to doctors to conduct the exam. So these are being litigated. So this goes back to what I said. The one thing we should know is how to determine when somebody's dead. And now, because we have this litigation going in, you can't do these tests. And they had said the mother had the sole authority to make these decisions. So I think in those scenarios, maybe if they had just posed the question differently, or the thing to say, we're just doing testing about the care plan. I'm not saying that's a skirt around. I'm just saying it's a communication technique. New Jersey is interesting in that a person can refuse, even if the determination of brain death has been made. They meet the criteria. They can say, I don't accept it. And then you do not withdraw organ support. So they can have a religious or philosophical. I think a lot of that comes from, they have a significant population, a Jewish population of Orthodox Jews, which relates to a person's not dead as long as they're breathing. And I guess that applies to even if they're breathing artificially. And so they can have a religious opposition to this, in which case the hospital then cannot withdraw this organ support. And so, these are some of the reasons that you see people, I think, refuse, because once the determination of brain death has been made, surrogates have no more rights, because person's no longer a patient, they're a corpse. We don't have a duty to do anything as healthcare providers or as a hospital to a corpse. And so also at that point, some of the organ procurement agencies can take over if the person has designated themselves as a donor. And they have a lot of rights in law of things that they can do and provide for these people after the determination has been made. So there's that. So there's the legal tactic. If you can't do the test, I still have control, and I can ask for treatment. Religious objections. These groups have no religious objections, and this constitutes about 6 million Americans. So the potential for coming up with someone with this particular objection, and I don't know each one how their objection plays out theologically or philosophically, or but I think the Jewish one I understand about the breath thing. But the notion here is the potential for coming across one of these challenges may be very significant. So the claim that testing is dangerous, that, as I mentioned, you might kill them by trying the testing, doing the apnea testing might cause further injury, which is why the cerebral blood flow study is recommended for patients that are unstable, if they can't tolerate that. And then there's if we don't do the test, then there can't be dead. So how would we proceed if the parent is declining this testing and refusing this diagnosis? What should we do at that point? Any suggestions?
Dr.
So I think try the best to keep those lines of communication. Understand that most of their objections are coming from a place of pain, that they're concerned about their loved ones. Journey with them, answer the questions, find out what the basis of the objection. If it's about it's going to make things worse, we can explain that. If it's about a miracle, that one we're not going to be able to explain. There's some questions. I think one, get pastoral care involved, certainly, or find out whatever their faith tradition is and try to speak to them on that way. And that's when the whole team pulls together. But if it becomes intractable in some of these cases, it might be you have to get risk management or legal involved. That it seems like this is not going to be resolved easily at all. So it's probably one of those cases where if you've seen one, you've seen one. Right, we're going to have to navigate them all using the unique situation and what's going on with that. Like the lady that thought there could be a brain transplant, to understand really her understanding of what's possible. Because I think if you watch enough TV, it probably is. So this one is where the guardian objected to the test. And the court said that they can, for that particular hospital, do it against the guardian's wishes. So the court ruled against the guardian on that case. And so that's one of the other issues of once we get it into the legal system, it can be all over the place. One state, yes, one state, no. And then it's whether the testing is permitted, whether or not the testing is positive, and then they're determined whether or not they can philosophically or religiously object to these things, and it becomes just one of these sort of nightmarish issues. And so, this is the fellow, Zach, we saw earlier, that he tested positive, but 36 hours after the accident, he was declared brain dead. This 36 hours is a very interesting thing that's come up recently, in that when you speak to neurosurgeons, they're saying because of the issue of cerebral edema, masking this, if you don't give enough time for the cerebral edema to go, and sometimes they'll say 72. So premature testing can give you a different result. So I think that's one of the things to certainly as the clinicians to examine the scenario, the underlying scenario, the notion of this cerebral edema situation and the potential for getting an erroneous result. Now they probably, I don't know if on him, I don't think they did cerebral blood flow studies. Wasn't completely dead. Not sure what happened in this guy's case either. So here's a bad exam. Let's see. He went to the intensive care unit to look at the patient. He called the patient's name, clapped loudly. They didn't wake up. He said, yep, he's dead, walked out. That's not, I don't think that was in our algorithm. I think that was in the old test, right? Let's say 3 times, and then they're supposed to wake up. But that one didn't go well for him. Marlise Muniz, she was the lady over in Texas. She was pregnant, experienced a PE, was determined to be dead by neurological criteria. She had previously stated if something happened to her, she wouldn't want to be maintained on technology. Her husband, husband, I think, was an EMT. She might have been an EMT when it was a firefighter.
Yeah, he was.
And
family.
And even their priest said it's okay to do that, even though her fetus was still alive. And so this played out in courts. What happened was in Texas, they had a law that says you cannot remove life support from a pregnant woman. And so the hospital said, okay, we have to comply with the law. You can't remove life support from a pregnant woman. And so they went through the court system, took a number of weeks, and then the court said, we're not talking about a corpse. We're talking about a living pregnant woman. So once she was declared dead, then the obligation to maintain life support was not there. So it was that sort of parsing out what the law was. And they made a film about her case as well. But we've seen more since hers. This young lady, this was in January, 6 months pregnant. Organ sustaining treatment. See, there's some good language there. And successfully delivered. And then there's another one. So we see these tend to get a lot of play too, because you have lovely young ladies in this horrible situation, and people are very interested in these. But again, even if we can keep the child viable, it doesn't guarantee, because sometimes what it takes to keep them viable with this organ support can be devastating to the fetus as well. So one of the things is after a person's been determined dead by neurological criteria is what do we have to do? Because do we just think, okay, send them to the morgue, whatever? But the compassionate thing to do for a lot of healthcare facilities is to give them a period of accommodation. Hey, can we have our family come in and say something or visit or whatever? So a lot of facilities will do 24, 48 hours to let people come in. If you had, someone deployed overseas, we want them to say goodbye or whatever. That's just sort of a courtesy that facilities, healthcare facilities tend to do these accommodations. And there's, this is in our policy, it talks about not accepting centers of death of PDS, or consciousness, or coma, or profound dementia. So it's just going along with the diagnosis of brain death. These are more of these cases where the family's battling, and then somebody gets caught in the middle. Here in this child, and this is a lawyer that writes these cases, so he said organ sustaining treatment. And so if death occurs, then they're moot cases. Failure to accommodate. This is that New Jersey and California I've mentioned about, where they have religious objections, and then the hospital does not accommodate the religious objections. So there's this uncomfortable mix between what clinicians know is going on and then what the law is requiring them to do. So these are these sort of emerging trends, medical death versus legal death. So when I mentioned that legal definition earlier on, it said death of the entire brain and brain stem. Question is, does that mean every single cell in the brain? If we say entire brain, somebody could parse it out and say, yeah, if I'm going to say entire brain, I mean the entire brain. And that has been a problem, because oftentimes these patients still have hypothalamic function. They're maintaining their electrolytes. So they should generally, you see diabetes insipidus that have real problems, and about 50% of them don't develop diabetes insipidus. They're maintaining their blood pressure. And they can also, some will actually, children will begin to go into puberty. So if that's happening, we know the entire brain is not dead. And so that's where there is this argument that has really got steam, the mismatch between the clinical determination and the legal definition. We've all accepted the clinical determination and understood we're not meeting the legal definition. And that has really gotten people concerned. So this person says, a substantial portion of patients declared do not meet the legal definition. So that really can get you worried. So any of y'all that might have followed Jihad at math when that happened, 13-year-old girl, she had a tonsillectomy, bled a lot during, there's probably some care issues there, bled a lot, went into cardio arrest. They resuscitated her and was successfully, but then they determined she was dead by neurological criteria. Two of the top pediatric neurologists in the country determined she was dead by neurological criteria. The family objected to that, and they took her and flew her to New Jersey, where you're allowed to have that religious objection, to where she was maintained in New Jersey for almost 3 years on mechanical ventilation and support. The family still saying she was not dead, and would release films saying she had movement. You can still have spinal reflexes with brain death. And it was thought those were spinal reflexes. She went into puberty though. So there was that argument about the death of the entire brain. She went into puberty. And then while it was working its way through the court system, she eventually had a cardiac arrest. So she had 2 death certificates, 2 states apart, 3 years apart. This was how this one played out so long. So you see she's 15 there. It was 13 when it happened, when she originally coded. So these, the notion of the legal part, that's going to be ongoing. They tried in the last year to have the uniform definition of death altered to match this, not to leave out that entire brain and brainstem, because we do know that a significant portion of patients do maintain some hypothalamic function, but they're still not going to recover. It's still devastating. And generally, in these cases, over time, the person's they're going to collapse physiologically, but it might take a good bit of time when in a sense of justice, that ICU bed could have been used for someone that might recover, because these people are not going to recover when we do this correctly, diagnose it correctly. The other issue of the apnea test is they're recommending to sort of affirm absolutely brain death is this sort of 4-vessel angiography of the brain to determine that there is no cerebral blood flow. There have been other studies about variability of reading some of these films, or the physicians, because when you see the scintillography ones, those are, for me, it looks like a pixelated, screen. So the notion of whether or not there's any bit of circulation to the brain also, and that lends itself to the diagnosis. And I think it's sort of confirmatory with the clinical exam of the apnea test and those sort of things. So at this point, any thoughts, questions, observations that you may have come across? Concerns? So it continues to be quite vexing, and there's a lot of effort in the ethics literature along with the clinicians to sort of sort these things out, because now it's what was really a clinical situation has fallen into sort of a legal morass. of, that can be very challenging, especially when dealing with families that are, challenged with this devastating information. We'll continue to see, I think, patients that have these types of injuries in the ICU. If y'all need assistance with anything, but I think one of these, the real soft skills that will help navigate these are the communication skills with the family, to very compassionately navigate these conversations, because really what they want to know is that their loved ones cared for, and that they were a person that meant something. And so to really just sort of say, I just can't imagine, what this must be like of how dealing with this scenario, and then gently sort of see how the situation unfolds. But if you sense that it's really getting a little bit deeper and they're making some claims that seem to be worrisome or those sort of things, I think that's when you call in extra help and say, hey, what can we do? But again, hopefully they already got some family, emotional support, pastoral care, whatever they use in their tradition, if they have a tradition, to help along the way, because these are the sort of the most unfortunate types of situations. What else? Yes.
Thank you very much. My question is this. We spoke a little bit about California and New Jersey. Can you comment a little bit about Louisiana and where kind of we are legally wise? I'm usually the second physician brought in for the confirmation of brain death, but I don't think the residents are completely aware of what state's rules are.
Yeah. So in Louisiana, it doesn't speak to any sort of requirement that I know of consent for the testing. And then the definition meets that same uniform definition of death of the entire brain and brainstem. And so, in most places, there's also been this dispute of, because the courts didn't say when they created this definition of the method of determination, they didn't say use the American Academy of Neurology or use this group. They would just say some authoritative source. Generally, everybody defers to American Academy of Neurology sort of algorithm of this determination. And that's been generally accepted. They rewrote theirs recently about the pediatric, including the pediatric and the adult of the testing, trying to refine it a little bit. So the courts have never said exactly what method you should use. They just sort of said some acceptable method. So right now I think we're in a good place as far as doing that. And that case I mentioned, we didn't want to get into what I would think would be a bad place of having to get that consent. Now, you'll get just as many ethicists saying, I think we should get a consent, right? They're all saying you get, 3 ethicists together, you get 5 opinions. They're gonna, so some may feel, well, it's fairly significant testing, maybe we should get consent. I think in the notion of ethics about autonomy and getting people to the whole informed consent, sometimes we give them so much information that they really can't know what to deal with. It can be a challenge because we're saying, here's a bunch of information, make a decision. And then they're just like, I don't know. Give me everything, because I don't know. I don't want to decide, make a wrong decision. So that's why we have, I think, more patients, families do everything. This notion of futility, care futility, and especially during COVID when they couldn't come to the hospital and see their loved one. It's like, we think, grandma's not doing well, and we may want to consider withdrawing technology, life support, do everything. Because I can't be there, I haven't seen them. Whereas if you see the person, you see, oh, they're really not doing well. So I think that notion of we're asking a lot. The other studies have shown when we ask family members about withdrawal of care, that they will have PTSD for up to 2 years because we're asking something of them, because they're going to second guess themselves on a Monday morning quarterback and say, I killed my loved one. They're going to get some new piece of information and say, oh, maybe there was some hope that they could have survived that. Well, at the time, with the best information available, there wasn't that. And so they're going to Monday morning quarterback it. And so we're asking a lot. I had to give consent for withdrawal for life support for my mother and my brother. I'm an old ICU nurse. It was hard. And I know what the deal is. Imagine families that don't and how difficult these things are for them. Because all they know is, I have a loved one that I'm losing and it hurts. And so processing that information, and God forbid they get on the internet nowadays with, the disinformation that's out there. So you're going to have more and more of those challenges of dealing with disinformation, I think, as time goes on, which means you're going to have to spend a lot of time explaining things, to them. And so you just sit down and say, I understand and I understand. And sometimes I feel like you're beating your head against the wall with those sorts of things. But it's just what it takes in order to help navigate these. And we hold each other's hands as team members and try to navigate them together. So that's where you can call on any of us that can help with us. And thanks for the clinicians. I know in that situation of the child where the mother was hoping for the miracle and all, and we thought, let's call the pastor at their school, because he went to a religious school, and that he said, she's difficult to deal with. I don't even want to touch that situation. So he was aware of that, and because she had a psych background as well, which adds to the mix. So these are the kind of worst case scenarios that we get into, and they're challenges. They're not easy, but that's when we work together and use the best tools that we have. And so, any other thoughts? Questions?
So one of my patients was immune, and I was on the palliative care and ethics committee for JPS. So that family was very educated. So it was a lot different. 2 years earlier, I had a similar case. Basically, the same thing happened. And that family was a migrant workers, didn't understand healthcare in general. I actually did have to keep them alive on a ventilator for a year until that baby was born. So it's kind of different. This family actually reached out to ethics and palliative care at the same time and asked for it to withdraw and everything like that.
Now, so Texas, Red's in Texas, right?
Yeah.
So Texas has what's called Texas Advanced Directive Act, CADA, what we call it. Now, that was what was supposed to help, except for that carve out with pregnant women.
Yeah.
Was in intractable cases, if the family says, no, I don't believe in this, and the care team is saying, this is futile care, it's not medically beneficial, then they have 10 days and say, we're going to give you a 10-day warning, and you can find somewhere else to move your loved one, which the chance of that to me are going to be slim, right? You're going to call up another hospital, say, take care of my loved one that this hospital doesn't want. It's probably not going to happen. And then the hospital, without legal liability, can withdraw life support or whatever.
Yeah, you basically have to get the ethics committee involved. So I sat on the ethics committee for futility care cases. So then they give the family 10 days to find somewhere else. Of course, no one will take. So this one that was pregnant, no one would. We called over and over, and no one would take. So you do have to then keep them all basically.
Yeah. So those are those sort of, again, legal clinical anomalies. And ethics, we generally say, a lot of our ethics problems are man-made because they're technology induced. So we didn't have to worry about these situations until the ventilators came about, right? We didn't have to worry about whether to continue dialysis till the dialysis machine. ECMO is its own thing as far as when to withdraw ECMO when there's no hope for a transplant, right? The code of bridge to nowhere. So our technology is always pushing us into new ethics, conundrums that we navigate, very prayerfully and diligently with a lot of consideration and using as much expertise from science and healthcare that we can to come up to something that we feel like is generally accepted in society. Anyone else? Yes.
Is there any impact on how declaration of death is done outside of the hospital setting? Because, previously I was the medical director at a nursing home for several years. It was my job to declare death in the nursing home. I had absolutely no technology at all available to me, and that was an extremely stressful, worrisome experience because I was basically just listening with my stethoscope and trying to figure things out. So, has there been any impact? We have EMTs declaring, death on arrival at a scene. We have nursing home patients being declared. So
I don't know the law because I know that coroners, right, can do it, and coroner people are not all medical necessarily background. They can just recruit from anything. and trained on it. I think in those scenarios when you're being called in, that's almost always going to be cardiopulmonary because they've been laying there quite some time. It's probably not going to be good by the time you get there and you're doing that exam. So, but let's say that there was some other scenario because you don't know, maybe, they took a lot of DIG or they took a lot of some other benzo or something and it could be mimicking. And then later on, you like, listen, I don't think, and then all of a sudden you see them start kicking around and thrashing like, okay, then what to do, right? Because, this is not going to go well. We've got a protracted anoxic period here. What is the duty now that we have to call 911? So they're the advanced directives. And that's where nursing homes, I think, are required to have the person's advanced directive on file to know whether or not they would want.
We'd have, DNR patients, some were in a vegetative state. So you really could not tell because that patient normally just laid there unresponsive at all. And so, with a decreased respiratory status and slow pulse. And so, so it wasn't a matter of, do we need to call 911 or not? It was just a matter of this time.
Yeah.
And so, so I was just curious if all of these legal implications and changes in definitions have had any impact on my process.
We began a few years back in Louisiana the post form, and you may be familiar with it. And the notion there is, so if you write a DNR order here in the hospital, it stops the second somebody's discharged. And so if they're being transported to a nursing home, and they were no code here, but then they get in the ambulance and then they code, they start doing resuscitation and they bring them right back because it's one of the few interventions, CPR, that doesn't require a consent and is presumed that was not the original design. It was designed for young people that have, a heart stoppies and all that. But now we get, old people like me and then, a ton of comorbidities and they resuscitate them over and over. So the notion of opposed was it's a physician order that is transportable. So it carries through the ambulance ride and it stays at the nursing home and they can carry it, it's at their house. So the notion of creating this. Now, it doesn't mean everybody's going to be in no code. You can be full code on it. So it just is your advanced directives in the form of physician's orders. And so, and whether you want artificial nutrition, hydration, whether you want intubation and all this sort of the menu list of things that a person would want or not want. And we have to remember that advanced directives are a point in time with somebody's wishes. So if I was diagnosed with cancer early on, I'd say, hey, give me everything because I want to see my granddaughter graduate and get married or whatever. After 8-9 months of therapy and, the tumors are bad and I'm sick and tired of being sick and tired, I might say, okay, I'm ready to change that. So that's why anyone that comes in with advanced directives should have the reviewer like, are these still your wishes? Because they can change over time very significantly, especially with people with a lot of comorbidities. And some of them will say, I knew, someone, that had this and they did terrible. This is another thing from my personal experience about people with chronic pulmonary disease. They've been intubated once or twice and they're like, I don't want to be intubated, put on a ventilator again. But when you feel like somebody has a pillow over your head and you can't breathe, all of a sudden you might change your wishes. And some of those you'll see, and even on the post, and this is another legal controversy, it says on the back, the surrogate, their healthcare, authorized healthcare representative can change the orders. So they're in the ICU and it says they want to be a DNR, and then the son or the daughter says, no, let's make them a full code. The notion there is to say, do you have new information about that? Because if we can change that with new information, but just because you're dealing with childhood guilt, that's not new. I'm just reading into that. But so sometimes in those conversations, and someone wants to change what you know and it's documented someone's wishes, we need to do some research on why is it you're wanting to change their wishes? Because they told us these were their wishes. So it needs to be fairly compelling if they were trying to do that. So again, those are the kinds of situations we'll bring up to risk, legal and all that. If it gets intractable and you're like, no, this really, oh, look, they signed that in the post yesterday. You signed it. And now all of a sudden you're changing it. What? And so we look at the scenario, the total picture to see how's this playing out. So there, I know all these were off of brain death, but all these are sort of interrelated in that we're dealing with usually patients and family members and surrogates that are in these very challenging situations.